members of Telangana Association of ENT. We have started a series of monthly webinars in which we will be inviting doyens in their field who will be making us go through by a handheld approach from the basics to the advanced in the recent field of ENT, the recent advances. As part of this webinar, we have a very well-known ENT legend, Dr. Sam Deendayal, who is a pioneer in Sialendoscopy in India, and by his effort, I could see Dr. Francis Marshall coming all the way from Europe, and I have an autograph. I feel very proud that we could see the world leaders also in this field in Hyderabad. Today, I'll request Dr. Sam Deendayal sir to give us an approach to all the salivary gland diseases in which traditionally we have been incising from outside, giving a scar to the patient and also some neurological problems. He will take us into all the realms of Sialendoscopy. I request Dr. Shekhar Reddy sir to take over and preside over this webinar.
Thank you, sir. Thank you. On behalf of AOI Telangana, I welcome you all for this webinar. This is in the series, this is the third. Initially, we did in the two topics, that is endoscopic ear surgery. After that, nose sinus surgery topic. This is the third one. In two more also they are in the pipeline, like rhinoplasty and regarding vertigo and also. I really appreciate Sun Pharma people for coming forward and organizing this. And today his speaker, I don't think so. He's a all-rounder in this South India. And he was the first person to start this Sialendoscopy, Dr. Deendayal sir. And I'm very thankful to him for accepting our invitation to kindly provide this webinar. Over to Shakuntala madam. Thank you.
Good evening, everybody. Thank you, Team AOI Telangana, for giving me the opportunity to moderate this session. It is indeed a big honor for me to moderate Dr. Deendayal sir's talk. Sir is a legend, as Dr. Anand and Dr. Shekhar Reddy have mentioned. He does not need any introduction. However, as a formality, let me just speak a few words about sir's history. So basically, sir did his undergraduation from Kakatiya Medical College, Warangal, followed by post-graduation MS and DLO from Osmania Medical College. And then he was trained in micro ear surgery, nasal endoscopy surgery, phonosurgery, radio frequency surgery, snoring and OSA surgery from USA. And in fact, sir was the first ENT surgeon in India to use radio frequency in ENT surgeries way back in 1996. And he was also the first ENT surgeon to perform siloendoscopy in South India. Sir is the member of American Association of Otolaryngologists and Head Neck Surgeons. He's a life member of AOI and has been the past president of AOI Hyderabad. He was the organizing chairman of the first Endocon held in 2003 at Hyderabad and the organizing chairman for the phonosurgery workshop held in 2006 in Hyderabad. Also, the organizing chairman for Sialendoscopy workshop in 2010. He was the organizing chairman of ISACON in 2015. He has been a guest faculty in cadaver dissection courses, several surgical workshops and conferences. And he's a patron of Indian Association of Surgeons of Sleep for Sleep Apnea. Sir has several publications, about 14 publications in Indian Journal of Otolaryngology and 2 publications in the American Journal. And also he has a book published on snoring and obstructive sleep apnea, which is titled as Management of Snoring and Obstructive Sleep Apnea in 2022. This was published by Springer. And he has been awarded with the Bharatiya Chikitsak Ratna Award in July 2010 by the Council for Economic Growth Research in Mumbai. Over to you, Deendayal sir, to take on and teach us, all of us, about the novel approach to inflammatory salivary gland disease through Sialendoscopy. Thank you, sir.
Thank you. Thank you, Dr. Shakuntala, for your introduction. And good evening to one and all. At the outset, I would like to definitely congratulate the AOI Telangana branch, especially Dr. Shekhar Reddy and Dr. Anand Acharya for starting this webinar teaching programs. They would be a great help, and I definitely look forward for many of these webinars under their leadership. And the topic that was given to me today is on sialendoscopy, otherwise called salivary gland endoscopy, where it is used in inflammatory salivary gland diseases. So when you look at salivary glands, inflammatory and non-inflammatory are the type of conditions that we see. And all the inflammatory conditions, most of them can be managed with sialendoscopy. If you look at the history, I would say that somewhere around 1994-95, sialendoscopy was introduced by two main people, Nahileli and Marshall. Nahileli is from Israel and Marshall is from Switzerland. Both of them have done some wonderful work in this. And if you look, that somewhere in 2010 Feb, we started in Hyderabad sialendoscopy. And before me, it was Dr. P.P. Singh from Delhi who started somewhere around 2007. So we have about in India, roughly about 15 to 16 years of experience in sialendoscopy. If you look at the definition, a sialendoscopy is a method of visualizing parotid or submandibular ducts for any pathology that is present. It is the duct and not the, the gland tissue. It's all visualization of the ductal system. And when you look at the indications, on one side, if you see that you have here all the, pathologies that are seen in the duct, right from stones to sialectasia to strictures, polyps, kinks. We've even seen foreign bodies. The commonest foreign bodies that are seen is hair or sometimes even a fish bone and some anatomical malformation. On the other side, if you see, it is all parenchymal diseases like recurrent juvenile parotitis, chronic recurrent parotitis, Sjogren syndrome, or radioactive iodine-induced parotitis. Whenever we say that there is sialadenitis, there is inflammation of the parotid or submandibular gland, I want you all to keep in mind in the inflammation that there is always a ductal pathology. Without a ductal pathology, there will be no sialadenitis. That means the inflammation would have happened in the duct, narrowing the duct, inflaming the duct, or narrowing the lumen of the duct with strictures or stones, thus resulting in sialadenitis. That is the first fundamental thing I would definitely want everyone to keep a note about. So when we look at, for example, salivary stones, actually the cause is not known, but there's a lot of hypotheses, right? From presence of bacteria, foreign bodies, cellular debris, microliths. And interestingly, there is no correlation with calcium, but typically it is seen more in cases with who are tobacco users. A little workout pertaining to the tissue inflammations like juvenile recurrent parotitis. If you look at it, these are normally seen in children anywhere from 8 years to 16 years of age. And it could be unilateral or bilateral, and it recurrently comes with episodes of swelling, pain, and fever. And if you look at it, that if you give some anti-inflammatories and antibiotics, it comes down and again it recurs back. And here, the main pathology is in the ductal system, and the parotid glands are the one that are affected and not the submandibular. And most of the time you see that there is infiltration of the gland with lymphocytes, especially when you take a tissue and test it with ductal cystic malformation and stenosis. Similarly, in chronic recurrent parotitis, this is seen in adults. And a similar sort of symptoms like that of juvenile recurrent parotitis occurs. Here again, if you see, there could be a single or multiple stenosis, giving the duct a look of a string of pearls appearance. And this again affects mostly the parotid gland. Sjogren syndrome, we all know that there are two types, primary and secondary type. And in the Sjogren syndrome, most of the time there is dryness of the mouth. And here there is severe ductal stenosis with recurrent parotid inflammation. Here again, submandibular glands are not commonly affected. It is mainly the parotid gland. And you have to keep in mind that this is a systemic condition, and the treatment with sialendoscopy takes care of symptoms pertaining to the parotid gland, not as a Sjogren syndrome in total per se. And the post-radioactive iodine strictures are typically those patients who have CA thyroid and who have undergone radioactive iodine treatment. And these patients develop recurrent parotid inflammations. There again, they found that there is periductal inflammatory infiltrates causing narrowing of the duct and formation of intraductal jelly-like plugs. These cases do very well with sialendoscopy and injection of steroid and an antibiotic. And in fact, one such injection of steroid and antibiotic into the duct and into the gland sometimes alleviates the symptoms for years together, and the patients do very well. If you look at the contraindication, the only contraindication is an acute sialadenitis. There is no other contraindication. And when you look at the sialendoscopes, there are two types. One is called the modular type and the other one is all-in-one. All-in-one means that the optical, working and irrigation channel are all incorporated. This is an all-in-one. Whereas this one is modular because the outer sheath can be changed to different sizes starting from 1 mm to 1.2 to 2.3 to 2.9, depending on which gland duct are you putting in and the age of the patient. So modular is more versatile. All-in-one is comfortable that everything is in one. And these are all semi-flexible, scopes, and it has distal lenses and a light carrier. And this is where the camera has to be fixed, and this is the light carrier source that is there. And with these sialendoscopes, you can do both diagnostic and therapeutic. It can be used for both the applications. So there are simple instruments that are present. You know that a duct has a punctum, and the punctum is the narrowest part, and the punctum has to be dilated. These are all varying sizes of punctal dilators, and this is called as a conical punctal dilator. These dilators used mainly to dilate punctum so that the sialendoscope can be passed. And there are very few instruments. If you have a look, there are a couple of instruments. One is a stone grasping forceps. The other one is a biopsy forceps. And these are all dilators. And this is how the modular sizes look like, where the sheets can be changed. And of course, you have a couple of forceps and a conical dilator. That is all is the instrument set that is required for you to do sialendoscopy. So whenever you do the sialendoscopy, you are more concerned about the duct rather than the gland per se. So you have to see that when you're looking at the parotid duct, you should know that it is roughly about 5 to 6 centimeters. And look at the diameter, 2 millimeters. And you can divide that into 3 parts. The distal, starting from the punctum to the buccinata muscle. See, you see from here, this is the punctum to the buccinata, whereas the middle is over the masseter. and the proximal is in the gland. So you divide it into 3/3, and then that is how you would anatomically say where the stone is or where the pathology is. Similarly, if you look at the submandibular duct, this is also 5 centimeters, but you look at the diameter, it is more. It's always the submandibular, which is larger in dia than the parotid. And this again is divided into 3 parts. The first part is the distalmost one that starts from the papilla to the beginning of the sublingual gland. You will be surprised that the sublingual gland is quite a big gland. And the second part starts from the anterior end to the posterior end of the sublingual gland. And the third part is from the posterior end of sublingual to the crossing of the lingual nerve over the duct. So these are the 3 areas where you know, and beyond the lingual nerve is the hilum of the submandibular gland. Once you have an idea about the anatomy and where you are putting your scope, you should also have a rough idea in terms of what are the investigations we need to do when a patient with recurrent inflammations come to you. Once upon a time, we used to use X-rays, and also we used to use sialography. Nowadays, we hardly use. The reasons are very simple. There are a lot of negative points. It's an invasive procedure. There is a possibility of irradiation. It can be painful. And you don't get that much of pathological evidence while doing a sialography. So when you look at a CT scan, you got to understand one very important thing. CT scan is not the first tests that need to be done in any inflammatory salivary gland diseases. CT scan is only used when you suspect an abscess. You got to remember that. And you will not get any precise information regarding localization of where the pathology is, except that it shows, for example, here there's stone here, but you do not know exactly where it is. And any stone below 2 millimeters cannot be identified by CT scan. And there are certain non-radiopaque stones. Those cannot be seen. And you will never get any information of the ductal information, pathology. So CT scan is only where you suspect an abscess. Otherwise, don't. This is the investigation of choice, ultrasound. It is best, cheap, no radiation, and normally you need a linear probe with a color Doppler with 7 to 10 megahertz. All stricture stones, sialadenitis can be diagnosed. But here there is a great negative point that we don't do it ourselves. There's somebody else who is doing it, and they are giving you the pathology, and you just read it because we are not used to reading our own ultrasonography images. So my suggestion to everyone would be to sit down with your radiologist, who is also an ultrasonologist, learn about the number 2, submandibular, number 3, thyroid. These are the 3 areas you should learn about how the ultrasound looks. It is very, very simple that you need to understand that right from the skin to deepest tissues it goes. And depending on the variation from gray to darker side, fluid, stones, muscle, subcutaneous tissue can be identified, and your radiologist will easily teach. And all you need to do is put a diagrammatic representation to them and say that wherever they see the pathology, let them put the diagram and then show where the pathology is. And when you repeatedly, interact with them, your end results of ultrasound will be good and you won't take it at face value. MR sialogram is typically indicated where the pathology is bilateral. Number 2, where you think that the disease is in the parenchyma. And here, one most important thing you need to ask for heavily weighted T2 weighted images. You have to understand that in this principle, stationary fluids are hyperintense. That means wherever there is saliva in the duct, it will show as a hyperintense thing. Here you can see typically pearl of strings appearance. This is in a chronic recurrent parotitis, where there is strictures and dilatation and strictures present. So you need to understand that MR cyelogram is, you can detect 100% stenosis, and you also have to understand sometimes thick mucus can also be interpreted as stones. Keep in mind cost factor. A submandibular gland excision for inflammatory salivary diseases is not indicated unless absolutely necessary. And you will see most of our submandibular glands, 50% of time when you do a biopsy, the gland is either normal or subnormal. That means you relieve the obstruction in the duct, the gland will come back to normal. So are we justified in removing a submandibular gland for just inflammation is a big question mark you need to keep in mind. Of course, we have to keep in mind the morbidity of the surgery and the common part of it of a marginal mandibular getting affected. Similarly, imagine a superficial parotidectomy for recurrent parotitis. Number one, inflammation. For you to get the planes would be a little difficult, and there is always a cosmetic part, a morbidity, and a danger to the facial nerve. So keeping a parotid gland excision to the last where there is no other way out is what that you need to keep in mind. Now coming to sialendoscopy, the most important part is training is crucial. The learning curve is steep. I mean, it's actually not exactly steep, but I'll say it's a slow learning curve. It took me roughly to become confident about 1.5 years, 1.5 years. And in true sense, I have realized over these past 13 years, the good old statement of a surgeon that the first 5 years is we learn how to do, the next 5 years we learn when to do, and the last 5 years we learn when not to do a particular procedure. That is the way that we really work out in terms of the procedure here. Now, the most difficult part of the sialendoscopy procedure is dilatation of the papilla. If you can dilate the papilla, because that's narrow, it is almost 0.5 millimeters. Your scope is more than that. Pediatric scope is 1.2. Adult scope is 2.3 to 2.9. So you need to dilate it, and under visualization is the most important thing. You can either use a loop or you can use a microscope. That is the best way to go about and dilate the papilla. And always remember, the submandibular duct papilla dilatation is more difficult than the parotid duct papilla, because the circular fibers are at the end in a submandibular, whereas in parotid, it is about 5 to 10 millimeters proximal to the papilla. Now, quickly looking at a few pathologies for you to have an idea. Whenever you pass a sialendoscope, you should look at number one, the lumen, number two, the diameter of the lumen, the content of the lumen. Number three, you look at the wall, the color of the wall, the blood vessels. And if you look at also some anatomical abnormalities like kinks, mucus plugs, and stenosis. So in this particular case, you can have a look that whenever there is a stone, there is always thick mucus coming in, and then the stone starts appearing in the lumen. And you have to always gauge the lumen size depending on the scope what you have put in and the duct which you have. Like I said, parotid duct mostly is 2 millimeters, whereas submandibular is between 3 and 4 millimeters. So you can have here stenosis being diagnosed clearly, And in these cases, you can have mucus plug coming in, and also some kink can be visualized. You can see kinks here. And here you can see the stone clearly seen. And this is an absolutely normal duct. So this way you can do your diagnostic endoscopy and correlate it with your investigatory findings, and then plan your action. Sometimes what we do is we combine diagnostic with therapeutic. For example, in this particular case, we have seen a stone, and if you look at the lumen size, this stone is small. This is hardly about 2 millimeter stone. So these are the cases we use a grasper, a stone grasper, and slowly hold it, and along with the scope, we gradually pull it out till the papilla. Because papillary lumen is 0.5, it cannot come beyond that. It is at that papilla we do a papillotomy and take out the stone. So stone removals can be done with the grasper. That is one. And in this particular thing, we have taken it out and the stone has come out. That is the way. And sometimes we have to use a wire basket. And this wire basket, depending on the stone, can be 3-wire, 4-wire, or 6-wire basket. And through the instrument channel, you can put the wire basket. And, once the stone is identified, you pass the basket. The basket is passed beyond the stone, and it is opened up. And once you open it, you try to engage the stone in the basket, hold on to it. And if the stone is smaller than the lumen size, it can be easily brought up till the level of the papilla, do a papillotomy, and then remove it. Now coming to stenosis. Now when you're looking in terms of stenosis, there could be single stenosis, there could be multiple stenosis. So we have a balloon catheter that can be passed through the instrument channel, and you can use some saline to inflate the balloon. So you pass the catheter beyond the level of the stenosis and use a balloon to dilate it and keep it there for about 15 to 30 seconds till the size is obtained to dilate the stenosed part. Many a time this single diaphragmatic stenosis is seen in quite a few cases of chronic recurrent parotitis and even juvenile parotitis. And this is how we try to do. And some of the cases, we can just enlarge these stenosis by increasing the size of the scope. Now we have two treatment concepts that are very popular. One is called the Marshall's treatment concept of recurrent salivary swellings. So he has subdivided into unilateral and bilateral. So keep in mind, wherever there is unilateral, ultrasound is more than enough. The minute where you have a bilateral, keep in mind the possibility of using an MRI. Both of them try and do a diagnostic sialendoscopy. And wherever there are stones present, you need to understand, depending on the size of the stone and the location of the stone, you can do different ways of removing it, either through wire or through a forceps. Sometimes you have this lithotripsy, laser lithotripsy using, or also you have this shortwave lithotripsy, you can even use that. Where there is stenosis, you can do a balloon dilatation, and if it's a large and longer stenosis, you can open it up by a combined approach. This particular group is called Erlangen group. The Erlangen group is from Germany. They have also got a beautiful series, and they have slightly divided it in a different manner. They have divided it depending on the gland and depending on the pathology. Like submandibular gland and sialolithiasis, they divided it into if the pathology is at the duct or hilum or in the gland. Where is the stone? Depending on where the stone is, then they viewed what is the methodology of going about and doing. But most of the time, if you see, it is either sialendoscopy or combined approach with duct splitting, or this is external shortwave lithotripsy. And you will see that only where there are multiple stones in the gland is where gland excision is indicated. Most of the time, it can be managed by sialendoscopy. This Erlangen group also came forward for the parotid gland and stones, same thing in the duct, in the hilum, and in the gland. And again, depending on the size and where it is present, a similar sort of a thing is viewed. So indication for parotidectomy is only where there are multiple stones and recurrent inflammations are coming, is where you have to think of a superficial parotidectomy. Similarly, for stenosis also, papilla, duct and gland, and there again you see it is sialendoscopy, and rarely do we do a parotidectomy. Similarly, the same thing for submandibular gland stenosis. This is a rarity. Most of the time, we can easily manage by sialendoscopy and what we call it as combined approach or ductal surgery. A quick look at what is a combined approach. Like, for example, for submandibular gland, dilatation is done, sialendoscopy is passed, and then you visualize the stone. And once the stone is visualized, you can either put a basket. Sometimes the stone is so big that you can palpate it in the floor. In that you don't need to put a basket, but you do a duct splitting right from papilla up to where the stone is. I normally use radio frequency here to have a bloodless field, and the stone can be removed. And once the stone is removed, you just have to stent the duct and put in a stitch. Never tightly put a suture because that will cause stenosis. As far as possible, do not suture over the duct wall. You suture over the soft tissue, which is superficial to the duct. Now, coming to parotid gland combined approach, there are two methodologies of doing it. One methodology is direct, where it's in elderly people and who don't mind a scar. And this can be directly visualized by seeing the light glow and then passing a needle onto it and then approaching directly from outside. And this particular approach is which is cosmetic, wherein you give a hairline type of an incision, like what you nowadays you standardly give for a superficial parotidectomy, and then dissect out the smash. And you see that when you put a sialendoscope and see, the area is looking bright over there and you can feel the stone. Make an incision on that, take out the stone, and then you don't close the duct. You close the smash, which is superficial to it, with monocryl in 2 different layers, and then later on suture back. And these cases we stent, and these are all for secondary ductules and tertiary ductules. Primary ductule level, most of the time we can do intraorally, going right up to the masseter intraorally. Now coming to holmium laser. Holmium laser is the one that is the laser for salivary stones. And you must know that the stones between 4 and 8 mm can be used. And the stones in the secondary and tertiary branches are best for these type of holmium laser usage. And sometimes stones beyond the stenosis, it will be helpful because you can open up the stenosis and also vaporize the stone. But keep in mind, a 2 millimeter stone takes 18 to 20 minutes. And the temperature is 499 degrees. And that's the size of the laser fiber to be used. And holmium laser is normally used by urologists. They use it more frequently for all the, what we call it as ureteric stones, for pelvic stones, and even for urinary bladder stones. And in fact, when I started first, I had taken a little help from a urologist because they're so used to it that it really does wonders. Patients do very well. And there have been a few cases I've done under local anesthesia. And you must know that holmium laser is a contact laser, and hard stones, it is difficult. Large stones, it is difficult. Soft and small stones, it does wonders. I mean, the patient is so happy later on. But you have to keep in mind some complications. One of the commonest complication is for perforation or iatrogenic stenosis. If you're touching, because it's a contact laser, if you touch the wall, that is what happens. So you always have to keep the lumen in mind, and whenever you are firing the laser and vaporizing it, it should be touching the stone and nowhere else. Difficult cases like salivary fistulas can be managed with, I've had 4 salivary fistulas, but this case I specifically put forward is a young guy, juvenile recurrent parotitis for about 6 to 7 years, and he had multiple salivary fistulae. There were 3 salivary fistulae down. And when I did, there was stenosis, and you have a look at the wall, pale, whitish, then there is a little bit of mucin coming out, and I had to go through, and you can see a diaphragmatic narrowing of the ducts that is being present. So after passing the sialendoscopy, identifying it, I have excised the whole fistulous area over there, and there again, the duct will not be closed. It is the tissue that is superficial to the duct that will be closed after excising. And of course, we definitely instill some antibiotic and some steroids into the gland. And this patient I have operated about 10 years ago. And today the fellow is an adult. He is about 19 years. Absolutely fine. So salivary fistulas that are very difficult can be managed with sialendoscopy. These are a few complications, and perforations I have seen, bleeding I have not seen, infection I have not seen, ranular neural damage I have not seen, but definitely perforations I have had a couple of, or even a little more. And I haven't had any stenosis, and emergency gland removal was in the initial part where I had put a basket for a submandibular stone in the hilum, which was almost about 6 millimeters. And this particular basket was, trapped, and I couldn't dislodge it. And for that, we had to open up and remove the gland because the basket was stuck. Here is something that I would like you to know. Just plain sialendoscopy, success is 80 to 82%, whereas sialendoscopy with combined approach or holmium laser and external shortwave lithotripsy, it jumps to 95. Quickly running through, you need to know, I have another 5-minute presentation before I close it. Large stones, you cannot really help them. You have to keep that point in mind. And too tight a stenosis, you cannot. And too long a stenosis, you cannot do much about. So there are limitations for sialendoscopy. A quick run through of our 13 years and 9 months experience. We have our publications. Our data of 2015 was published in 2016 of about 133 cases. As of now, we have about 402 cases. Our youngest is 3 years. Our oldest is 76 years. Maximum number of our sialendoscopies were done under local anesthesia. If you see, our maximum number is between 21 and 40 years of age. And you see that mostly it is males, and males more than females. And interestingly, if you see that left side glands were more commonly involved than the right side glands, and we had more pathologies in parotid than submandibular. And here, if you have a look at it, that when we have done the Sialendoscopies, that maximum number we could identify pathology. It was only about 30 of them. There was no pathology when we did a Sialendoscopy. So our diagnostic sensitivity was about 93.6. That is very high. And if you look in terms of the calculi, the commonest is the submandibular. And again, in that, the commonest are floating stones. And if you look in terms of strictures, the commonest is parotid. And if you look in terms of the abandoned cases while operating, you see quite a few parotid cases I have abandoned rather than submandibular. That is mainly because of stenosis. If you look at our experience of calculi, we have seen from 1 mm to 1.5 centimeter size. And again, combined approach maximum was submandibular, and parotid we only did 48. And if you see in our series, there were 24 cases where we had to do a gland excision. So roughly all of them were submandibular. And our gland preservation rate was about 83.3. And most of them had their calculi in the either intraglandular, submandibular, or hilar, along with either stricture, and 4 of them had abscess. We had done about 22 laser vaporizations, again in that more in submandibular, less in parotid. Our complications were parotid, but this is more. See, when we miss on the papilla, we end up making a false passage. That is something that we need to keep in mind. So in our series, about 3.9%, and we had to do 26 cases revision, and in which there were 2 cases where we missed stones and later on retrieved. 1 patient we lost from follow-up, 6 patients who came and refused repeat procedures. 2 patients after removal came back with recurrent calculi. So the question is, can the calculi come back? Yes, a rare possibility, yes, it can come back. And 2 patients had papillary stenosis. This is something that you need to keep in mind. Don't fiddle around too much with the parotid papilla, because if it gets stenosed, this patient is going to come back to you again and again. And we did about 5 cases in revision, laser vaporization, and 8 stricture dilatation. We have abandoned about 20 patients, 16 in parotid, 2 submandibular, and 2 cases because of tight opening at the papilla. We had all the time had false passages. These are our diagnostic thing, and you have seen that we have 4 salivary fistula, and maximum is chronic recurrent parotitis. More common than calculi. That is something that need to be kept in mind. So in conclusion, it's a novel approach for inflammatory salivary gland diseases, non-invasive or only minimally invasive at most. You do a combined approach. Radical gland excisions are avoided. Assistance for external approach in stone localization is achieved, and you get organ preservation. Revision and repeat procedures, if required, can be done. Interestingly, this can be done under general and local. You can use a microscope or a loop for papillary dilatation. OR time utilization is lower. Minimal post-operative care and can be done as a daycare procedure. Economical. Please keep this point in mind. 1 in 10,000 population requires Sialendoscopy. So if you take the population of Telangana, you'll know exactly how many cases for Sialendoscopy is there. There is enough and more scope for all my ENT colleagues to start off with Sialendoscopy, and especially in Telangana, Andhra Pradesh. Anybody who is very much interested, I'm very happy to help them out to initiate into Sialendoscopy. Thank you. Thank you very much. I'll be happy to take some questions.
Thank you, Deendayal sir, for the excellent presentation and sharing your vast 13 years experience on Sialendoscopy and on sharing with us the knowledge on the procedure itself, and throwing light on the indications for Sialendoscopy, the approach, the equipment required, and the methodology, the associated, what all the diseases can be tackled, using diagnostic Sialendoscopy, and the whatever procedures can be done also with that, tackling the various types of calculi in the submandibular and the parotid gland and the ducts. Also telling us about the various inflammatory disorders in the parotid and submandibular gland. Then also the investigations, the various pathology that we face, and also the treatment protocol, the Marshall's and the Erlanger's protocol. Also throwing light on the holmium laser, the limitations and complications. So thank you, sir. It was a very extensive and elaborate presentation. And I'm sure all of us benefited from this presentation. It's a very novel technique and something that all of us need to learn. And I'm sure that, sir, you will be able to guide and train us for those interested in Sialendoscopy, and in the future, train the future generation of ENT surgeons. So I have, before I hand over to Rakesh, I have just 4 questions, sir, about this presentation. One is, stricture, you said associated with calculi. What could be the reason for stricture associated with calculi if there has been no previous intervention?
So there is a possibility that the patient had recurrent parotitis. And whenever you see a chronic recurrent parotitis, there will be a history of mumps in childhood. So that would have caused a stricture, and that would have caused salivary stasis. Salivary stasis gradually has resulted in a silolith formation. So you cannot retrieve it, and it is difficult. So you need to dilate the stricture to go to the stone.
So you mean to say that in such situations, the silolith is secondary to the stricture?
Exactly.
Silolith formation.
Yes. And many a time that inflammation is active. I've had about 2 patients where the stricture was so big, especially submandibular, where we had to completely explore the duct, open it up before we went to the stones. And this patient had multiple stones. One large stone in the hilum and smaller stones in the proximal part of the duct.
So in stricture cases, what is the duration of the stenting, sir?
In fact, in a stricture case, I would put the stent for about 12 to 15 days maximum. Many a time within 10 or 12 days, the stent comes out. Anything beyond that, you are introducing infection.
Okay. So one more question is, what is the indication for combined approach in calculi, submandibular calculi or parotid? Most commonly in submandibular, what is the indication for combined approach?
Combined approach is where you are using an incision to take out the stone.
Yes, sir.
So, for example, submandibular combined approach is mostly intraoral, right from the papilla up to the hilum. You can do a duct splitting, or you can just incise over the stone itself. And secondly, again, it depends on the size of the stone. Suppose that the duct dia is about 3 millimeters to a max of 4. So 4.5 mm stones can be comfortably brought through, because once there is a stone proximal to it, there's dilatation of the duct. So you can bring it in a basket right up to the papillary level. All that requires is a papillotomy. But if the stones are larger, you can't bring them. That is where you have to do the combined approach to open up by duct splitting. Now, similarly, yes.
So after the splitting and removing of the stone, sir, what do you do? Do you close the duct again, or you marsupialize it?
So in fact, the thing is that if in the distal third, you can always put a stent. But as you go proximally, it is better to keep the duct open, not close. Similarly, in the parotid, mostly we bring the stone up to the level of the papilla incise, and we normally do not close because that can cause stenosis. we try to keep it as patent, as open as possible. The worst is the parotid. At least submandibular is very comfortable.
Okay.
And for combined approach, there are 3 ways of going about and doing depending on where it is. Number 1, intraoral, you can remove all the way up to the buccinator to the anterior wall of the masseter, anterior portion of the masseter. You can comfortably remove it intraorally. Externally, if the patient doesn't want a scar over the masseter, you can remove it externally from here. Intraglandular, you have to give them a choice whether they want an incision, or you can make one of the superficial parotidectomy, the hairline incision, and then do it.
So one more question is, in the treatment of Sjogren syndrome, what is the role of sialendoscopy?
Sjogren syndrome is mainly ductal stenosis. And in ductal stenosis is primary and inflammation is secondary. So ductal stenosis, dilatation is done. And then the the gland is recharged by injecting some steroids and some antibiotics so that the inflammation comes down and the patient feels much better.
Does it also increase the salivary secretion, sir? Because some literature has quoted that.
Partly.
Yes.
I will not say totally. It all depends on the severity of Sjogren's. There are some Sjogren's where I've seen the whole duct is stenosed. You can't even pass a 1.2 scope into it. That's something that we can't. That's the reason why, if you've seen, there are quite a few parotid cases abandoned.
So one more question is, if the stone is impacted in such a way that the length of the stone is at right angles to the axis of the duct, that means it is not it's not aligned along the long axis. In such case, what do you do?
Combined approach.
Okay.
You have to do a combined approach. There's no other way you can bring it out. Always remember the diameter of the duct and the stone. The stone is equal to diameter, lesser than diameter. Comfortably, you can retrieve and bring it out. Anything beyond that, or a fixed stone, we call it as a fixed stone. That means it is attached to the wall. Those you can't. Those can be laser vaporized depending on the type of stone it is, or you can drill it. Nowadays, you even have manual drills to drill it.
Thank you, sir.
Oh, you're welcome.
Sir, Deendadayal sir, I have a few questions, sir.
Yes, please.
Sir, very well explained that sialendoscopy is a nice diagnostic and therapeutic tool for the ductal system rather than the parenchymal diseases, sir. Sir, have you come across a phlebolith? Phlebolith is the commonest differential diagnosis for this salivary gland caliculi. Have you come across, and how will we differentiate that MRI or ultrasound phlebolith cases from these stones and all?
The phlebolith can be misunderstood and can be misdiagnosed as a salivary stone, but phlebolith normally is in the course of the blood vessels that are there, and the ductal anatomy, where you know where the duct is, your chances of making out the differentiation is definitely there. But phlebolith can be viewed as one of the differential diagnoses. See, in a phlebolith, you don't have recurrent parotitis. You don't have recurrent salivary gland inflammation, but on ultrasound or on a CT scan or an MRI, there is a possibility that you're able to pick it up. Symptomatology will be different. It will not be the same.
Sir, it won't kink the ductal system, sir? Ductal system, it won't know.
No, it will not. Phlebolith.
Sir,
yeah, please go on.
Okay. Regarding, I commonly come across this juvenile recurrent parotitis, sir. That 11 to 12 years boy coming and repeatedly asking. So what is the ideal treatment, and when we will say it is a juvenile recurrent parotitis? How many episodes in a year or like that, sir?
Even if the episode is 2 to 3 times, over a period of time, maybe 2 years, and the patient has swelling, pain coming in, it is always better to do a silendoscopy. I've done when the patient comes for the second time, and the youngest, like I told you, was 3 years of age, which we have done. And you can even do it up to the age of 16 to 17. Very interestingly, this juvenile recurrent parotitis after the age of 20, 18 to 20, they won't get these attacks. Later on, maybe they go into the chronic recurrent, but they normally their symptoms get alleviated the minute they attain 18 years of age. Yes, Anand.
If there is sialectasis in JRP, how do you manage?
See, JRP is stenosis and then sialectasis. That is proximal to the stenosis. The minute you relieve the stenosis, the sialectasis causes dilatation of the duct. So you go into the thing, then you instill the drug, your antibiotic and your steroid, and after dilatation, you will see that the symptoms alleviate. There are cases where one silendoscopy, the patients never came back. Sometimes these patients come for a second time silendoscopy after 1.5 to 3 years range. I've never done a juvenile recurrent parotitis a third time silendoscopy. 2 times the patients are fine. But I most cases bilateral.
One more question, sir. In that case, you had a recurrence of calculi after you did remove the once calculus.
Yep.
What is the pathology in the gland which makes the calculi develop again and again? Is there any way to prevent reformation of calculi by any medicine or anything?
I'll tell you. In fact, that's one of the reasons I put the word over there. These are the people who are smokers. It is proved beyond doubt that calculi are common with smokers.
Those who don't smoke?
I haven't seen that. This particular patient was a smoker. And mostly if there is a recurrence of calculus, either there is stasis, or the saliva is thick and there is certain microliths formation, and then, a little bit of inflammation, and slowly, the nidus for a stone formation starts. But definitely there is no clear-cut etiological point for a stone formation. There is all hypothesis why it is more in submandibular, because the saliva is going against the gravity, and all those things are all hypothetical, but nothing specific. Specific they have found in smokers. It has got nothing to do with calcium again. And maybe some people have that tendency, or there could be a ductal injury, we don't know, a subclinical inflammation that has triggered off the thing. These could be the reasons.
How often do you have to change silendoscope, sir? It being very thin, flexible. What are the economics involved?
I tell you, you treat a silendoscopy like a baby. I'll tell you truthfully, I have, as of now, 4 silendoscopes, and not even one silendoscope has broken. Only one thing, the lens has become very dull. So that's why I had to keep it to the side. But many of the people, silendoscopists, many a time the scope breaks.
What is the dexterity involved?
The point here is the person who is handling it apart from you should know exactly how to manage. Like, for example, I've been very lucky that I have a theater nurse with me, same theater nurse for the past 17 years. So the theater nurse and my same OT technician is for the past 17 years. So they know exactly how to go about and manage. More number of hands change, the silendoscope gets damaged. And it is pretty expensive. So we need to be like, there was a time initially, I used to clean, I used to pack, I used to take care of the silendoscope.
Sir, one question, sir.
Yeah.
There is an entity called sialendoscopy. Does sialendoscopy helps in this, sir? Sialendoscopy. Both parotid glands enlarged, 35 to 40 years, male patient, they recurrently come, sir.
Sialendoscopy many a time could be autoimmune.
Okay.
Many a time. And in these cases, intraparotid injection of steroids will do wonders. And in fact, in the sialendoscopy where there is no inflammation per se, and some cases have something like hereditary large parotids, they won't help them because it is asymptomatic and it has been there right from the beginning. Those cases you should not.
Sir, any particular diet we should avoid for these sialendoscopy patients? Any particular diet?
Plenty of water. Plenty of water. These patients will do wonderfully well, and that's why we give sialogogues, vitamin C and some lime. These are the drops that will produce saliva formation, and we should not have saliva that is thick. So you should not have a dry mouth. So anything that produces more salivation is welcome.
Dr. Rakesh, have any questions?
Sir, we received one question, sir. Dr. Aditi from Hyderabad is asking, what is the cause of ranula after sialendoscopy as a complication?
Yeah, that's a beautiful question she has asked. Ranula is always a complication of an injury to the sublingual duct. Sublingual duct. You will know that the sublingual duct opens into the submandibular duct, roughly about 1 to 1.5 centimeters from the papilla. So whenever you are a little rough with the duct and you injure the sublingual duct, that sublingual duct gets stenosed, blocked, and the saliva from the sublingual gland starts accumulating and becomes a ranula. And this is where I'll give you the catch point. Ranula surgery in once upon a time used to be marsupialization. That was the answer. But many a time if you do the marsupialization, it recurs again. If you don't want any recurrence along with your marsupialization, take out the sublingual gland. Okay?
That is the only question, sir, we got.
We got some compliments also. Dr. Ashok Kumar Singh is complimented. Always pleasure to listen to your lectures, sir. Dr. Ashok Kumar Singh has complimented.
Thank you.
Praveen, any questions?
Actually, I am very much blessed that I have seen directly the procedures done by Dr. Deenadayal, sir. Actually, I am a student of Dr. Deenadayal, sir, and have seen at least around 20 cases in my student career with the Deenadayal, sir.
I know, Rakesh, but
yes,
I missed your company in the later part of your post-graduation.
Yes, sir.
Once again, a wonderful presentation, sir. Thank you.
Thank you, Anand. Thank you. Thank you.
Rakesh, vote of thanks. Right? Rakesh.
Sir.
Vote of thanks.
Yeah.
Namul.
Hi. Good evening, sir. Very nice presentation, sir. Thank you,
Namul.
Good evening, Anand, sir. Shekhar, sir. Madam.
So, thank you, Deenadayal, sir, for your wonderful presentation. And thank you, Shakuntala, madam, for doing as a moderator. And thank you for participating, sir, on the survey, sir. And all the delegates. Thank you, sir.
Thank you. Thank you very much.
Bye.
Good night.
Okay.
Good night.
Good night, sir. Bye. Bye.
Good night, sir. Bye-bye.
Shekhar, thank you.
Thank you, sir. Thank you, sir.
Thank you. Thank you, Shakuntala.
Thank you, sir. Good night, sir.
Thank you, sir.
Good night, Kamal. Bye.